Good afternoon. I have the great pleasure today to be able to moderate this breast cancer tumor board for us. We're going to discuss some very interesting cases, complex clinical decision pathways, and I'm honored to be joined by my esteemed panelists. I'm going to start with Dr. O'Shaughnessy, if you would like to introduce yourself, and then we'll just jump right in. Dr. O'Shaughnessy.
Hi, I'm Joyce O'Shaughnessy. I'm a breast medical oncologist. I work at Baylor University Medical Center, Texas Oncology, and US Oncology in Dallas, Texas. Real pleasure to be here with everyone.
Hi, I'm Tom Buchholz. I'm the medical director of Scripps MD Anderson Cancer Center in San Diego, and I'm a breast cancer radiation oncologist.
Hi, I'm Rennie Butler. I'm an associate professor in the Department of Diagnostic Radiology and Biomedical Imaging at Yale. I specialize in breast imaging, and I'm delighted to be with you all.
Dave Mamones, a breast surgical oncologist. I work at Orlando Health Cancer Institute. I direct the breast program there.
This is a 73-year-old lady with stage 2B, ER, PR, and HER2 negative left invasive ductal carcinoma, grade 3. As I mentioned, the PD-L1 status is unknown, clinically node negative. She completed neoadjuvant dose-dense chemotherapy with doxorubicin, cyclophosphamide, and paclitaxel, status post-lumpectomy and sentinel lymph node biopsy, and partial axillary nodal dissection with a final pathologic stage of YPT2 N0, clinically M0. And the plan is for adjuvant left radiation as well as adjuvant pembrolizumab. And so the question being posed is any other further adjuvant treatment recommendations for this particular patient. Her clinical presentation included a palpable left breast lump. She has an excellent performance status. Her medical history includes hypertension, coronary artery disease, type 2 diabetes, as well as osteoporosis. Her gynecologic history includes achieving menopause at the age of 40, at which time she underwent a hysterectomy and oophorectomy, G3, P2, no significant hormone replacement, and so on. No significant social history. Family history is notable for liver cancer, no family history of breast or ovarian cancer. So in February of 2021, she had bilateral diagnostic mammogram, which demonstrated a lobulated irregular mass in the upper left breast, corresponding to the palpable abnormality. There were also several microcalcifications which were associated with the mass, and there was a small nodular density medial to the mass, which was noted that could possibly represent a small satellite lesion. Left breast ultrasound was completed, which demonstrated a hypoechoic mass at the 12 o'clock position, 4 centimeters from the nipple, with internal vascularity. There were associated microcalcifications measuring 2.5 centimeters in largest diameter. The left breast ultrasound guided core needle biopsy was completed and demonstrated an invasive ductal carcinoma with focal squamous differentiation. This was grade 3 with focal metaplastic, 5% metaplastic noted. As I mentioned, the prognostic markers were triple negative with a Ki-67 of 45%. She had a repeat diagnostic left mammogram and ultrasound, which we will go over in just a bit. And we will talk about the mid-treatment ultrasound as well. So Dr. Butler, if you might walk us through the initial ultrasound from March and then sort of after a few cycles of treatment in April.
Yes, these ultrasound images are taken about a month apart. The image on the left shows an irregular mass with lobulated margins and heterogeneous echo pattern. And although these are single images that may not have been obtained in the exact same scanning plane, the ultrasound obtained a month later does not show any significant change.
Perfect. Thank you so much. So subsequently in August of 2021, she underwent a lumpectomy with sentinel lymph node biopsy and partial axillary nodal dissection. Residual invasive ductal carcinoma was noted, grade 2, which was triple negative with a Ki-67 of 28%. The tumor bed was measured at 2.7 by 2.3 by 1.8 centimeters. The residual invasive tumor was 1.4 by 0.8 centimeters. The overall residual cellularity of the tumor bed, 30%, and 5 lymph nodes were negative. After consultation with the radiation oncologist, it was planned for her to undergo adjuvant radiation, and they are planning for adjuvant pembrolizumab as well. So the question being posed, what are further adjuvant treatment recommendations for this patient? So we might first start with Dr. Mamonis. Do you want to comment on the surgical approach? Do you agree with what's been done for this neoadjuvant triple negative patient?
Yes, I think the patient, despite the fact that she didn't have a great response, the tumor was of a certain size that would allow for breast conservation. I was in the upper part of the breast, which is more forgiving cosmetically. There were some calcifications. I would want to make sure that those calcifications are removed, maybe by bracketing the lesion, the residual lesion. And obviously, one comment to make that the ultrasound was performed mid-chemo, but typically we like to perform all the images again at the end of chemotherapy to assess for radiologic response and then make appropriate sort of adjustments to the surgical approach. But certainly it appears that the patient has negative margins, had 5 sentinel lymph nodes removed that were negative. So I would be comfortable with that. So I wouldn't necessarily feel that she needs any more surgery at this point.
Perfect. Dr. Buchholz, do you want to comment on radiation treatment planning for this patient that had a partial response to neoadjuvant chemotherapy?
Yes, I think the plan would be to treat the breast. I agree with Dr. Mamunis that the lymph nodes are adequately managed. She had clinical lymph node status at the onset, and the sentinel lymph node was negative. To treat the breast, you could treat either with conventional fractionations, which tends to treat the breast to about 50 gray or 5,000 centigray, as you described, or you could treat with hypofractionation. Cases with metaplastic components or metaplastic carcinomas tend to be a relatively radio-resistant histology, tends to be a little bit more chemo-resistant. So she's kind of showing some of that. And so I probably would do a tumor bed boost following whole breast radiation treatments to dose escalate the area of the tumor bed an additional 1,000 centigray.
Perfect. Okay, thank you so much. Dr. O'Shaughnessy, do you want to comment on the management of adjuvant therapy in general for this patient with, not a complete pathologic response with a triple negative breast cancer?
Sure. Well, since she started her therapy, we've had a change in the management now of stage 2, clinical stage 2, triple negative breast cancer because of the FDA approval of neoadjuvant pembrolizumab, which is now planned for her in the adjuvant setting. It was preoperative pembrolizumab along with chemotherapy, followed by surgery, radiation, and then adjuvant pembrolizumab. And the patient, that was not available when the patient started her therapy. And so I think it's reasonable for her to have the pembrolizumab, as she still has some risk. I was happy to see that she did have some a smaller volume residual disease, and I would have necessarily anticipated, which it was only 1.4 by 0.8 and only 30% cellularity. So that was encouraging that she did have chemotherapy sensitive disease. It just wasn't entirely sensitive. So I think it's reasonable, although we don't have data, it should be said, we don't have level 1 evidence that utilizing the adjuvant pembrolizumab when it wasn't given with the preoperative chemotherapy is of benefit to patients. We don't have that level 1 evidence, although many of us are needing to think about that because we have had patients who didn't get the preoperative pembrolizumab. So I think that's a very reasonable option. I will say that even though it's favorable that she's node negative, in the Keynote 522 trial that gave the preoperative pembrolizumab with the chemotherapy, followed by the adjuvant pembrolizumab, in the patients who were clinically node negative to start off with, they got a large benefit from the pembrolizumab. So even though she's favorable with the lymph nodes being negative, I still would consider the adjuvant pembrolizumab as is being considered. And so what else to add to the pembrolizumab, if anything? Well, one thing I would think about is a germline BRCA1/2 testing. She does not have a family history of breast or ovarian cancer, but now with the availability and the FDA approval of 1 year of adjuvant PARP inhibitor olaparib, I think it's important that we know the germline BRCA status, because I would be in favor of a year of the olaparib along with the 6 months of pembrolizumab if the woman had a germline BRCA 1 or 2 mutation, which is unlikely, but certainly not 0. But let's assume that the BRCA testing is negative. There's no inherited mutation. Then there's a couple of other things to think about. One certainly is the CREATE-X data, which had shown that in women with triple negative breast cancer who had residual disease following preoperative chemotherapy, that 6 months of adjuvant capecitabine chemotherapy improved both disease-free and overall survival. So that's a standard of care now for patients who are germline BRCA normal, wild type. And so that's certainly a consideration. We don't have data combining it with pembrolizumab in the adjuvant setting, although many of us are going to do that because the pembrolizumab is a benefit, the capecitabine is a benefit, patients still have considerable risk. And so putting them together, we know it's safe. We have adequate safety data. And then the other consideration is another set of new data, really very recently presented at ESMO from the Brightness trial, where women received preoperative carboplatin in addition to the paclitaxel and the AC. As this patient has had AC paclitaxel, there was a fourth drug added, the carboplatin, which improved invasive disease-free survival. And so one consideration would be, with the BRCA testing is normal, would be to give 4 cycles of carboplatin with pembrolizumab and then give the capecitabine afterwards. We don't have a right or wrong way to go on this situation. I tend to do everything I can in the setting of triple negative breast cancer with residual disease. And so if the woman were otherwise healthy, quite robust, I would consider 4 cycles of the capecitabine with the pembrolizumab, and then followed by the capecitabine for 6 months with the pembrolizumab. But I think one could just do the capecitabine with pembrolizumab as well, and that would also be reasonable.
Perfect. So just to clarify the timing of the radiation, if you were to choose a strategy that was something like the carboplatin and the adjuvant carboplatin and pembrolizumab for 4 cycles, then would you complete that first, then do the radiation, and then finish the adjuvant pembrolizumab? Would you give the pembrolizumab concurrent with the adjuvant radiation therapy? How would you sequence those things?
In Keynote 522, the radiation therapy was largely, I say there was a protocol amendment, so it wasn't the entire study, but there was a protocol amendment that then allowed the radiation therapy to be given with the pembrolizumab. And I certainly favor that because I think there may be some synergy there. So I would favor the pembrolizumab during radiation therapy. She had small amount of residual disease, clear margins. And so I talked to the radiation oncologist. If the radiation oncologist was okay, I'd probably favor doing some adjuvant carboplatin with the pembrolizumab and then do radiation therapy, holding off on the capecitabine until the radiation therapy was finished.
So just to make sure I'm clarifying again, not really in this particularly high-risk patient, but to not really choose either or between the adjuvant capecitabine, but potentially consider sort of like you said, leave nothing really on the table, right? For this patient, that we do adjuvant carboplatin and pembrolizumab, then radiation, finish the 6 months of the pembrolizumab, and then consider adjuvant capecitabine. Am I understanding you correctly?
I'd probably add the cape as soon as the radiation therapy finished.
I see.
And overlap it with the pembro for about 3 months there.
Perfect. Dr. Buchholz, how do you feel about that timing, sort of like some adjuvant chemotherapy, then the radiation, and then finishing the more adjuvant targeted therapy?
Yeah, we don't really have a lot of data to guide us in this clinical situation, and so we kind of use our best judgment. I think that's reasonable. There are some things like pembro that can be combined with radiation safely. Other things you have to be a little bit more cautious about. Concurrent PARP with radiation, both of them can affect DNA damage repair processes. And while we do have a protocol looking at it concurrently in inflammatory breast cancer, I think that should be done only on clinical studies to really gain an idea about potential synergistic toxic effects. And likewise, we tend not to do concurrent Xeloda or concurrent capecitabine or concurrent platinum in the setting of breast cancer. So I'd be comfortable if there was a short duration of platinum-based adjuvant chemotherapy to follow radiation subsequently. But there's no real data to drive the sequencing of adjuvant treatments in this setting.
Perfect. Thank you so much. Yes, I appreciate everyone's insight. This is very much a data-free zone. And we have, as we said, all of these new approvals, the adjuvant olaparib for our BRCA carriers. We now have the adjuvant pembrolizumab based on the keynote trial for patients who receive neoadjuvant pembrolizumab, receiving 6 months of adjuvant pembrolizumab. And so now these are clinical questions that we're facing, every day in our practices. And sometimes it's hard to know sort of how to optimally manage that for those patients. So just to summarize, everyone, I think we would definitely recommend, adjuvant radiation therapy, either conventional or a hypofractionated approach with a boost of the tumor bed. And then as far as adjuvant systemic therapy, potentially consideration based on the brightness data of adjuvant carboplatin for 4 cycles in combination with pembrolizumab, extrapolating from the keynote data, and then completion of the adjuvant pembrolizumab, as well as the addition of adjuvant capecitabine based on CREATE-X. So sort of summarizing a bunch of trials there that potentially would, we hope, result in the best outcomes for this particular patient. And we just can't be overemphasized enough that, as Dr. O'Shaughnessy mentioned, that all of these patients now really need to undergo germline BRCA1 or 2 testing so that we understand if we have an additional target in the form of adjuvant olaparib.